Good evening and welcome, everyone. I'm Jonathan Glashow. I'm a clinical associate professor in orthopedic surgery at NYU. Today's presentation is the Bear Journey, a 2-year case review. Throughout the program, I want to encourage you all to send in questions via the Ask a Question box at the bottom of your screen. At the end of what we present, we'll cover as many of those questions as time permits. Before we get started, I'd like to introduce my esteemed colleagues, Dr. Alex Meininger to my right, and Dr. Daryl Osbahr to his right.
Thanks, Dr. Glashow, and thanks everyone for joining us. My name is Alex Meininger, and I come from Steamboat Springs, Colorado.
Daryl Osbahr, I'm from Orlando, Florida, the Chief of Orthopedic Surgery for Rothman, Florida, and the Executive Medical Director and Chair for Advent Health Orthopaedics.
Great, thanks. Let's get started. So our Bear implant journey. So the Bear implant is different. So why is it different? We all know about ACL and ACL reconstruction. I'm sure everybody listening has done this for years. Some of us have potentially done primary repairs before the implant of Bear was available, and we talked a little bit about that before we came on. But the Bear implant is more of a restorative situation than it is simply a repair. It preserves native anatomy, as we know, restores the ACL by utilizing a bridging technique where a collagen graft is put in place, soaked in blood, allowing both ends to heal. So we know about blood clots and healing, and this is not a basic science review, but we can use the analogy of the MCL. And when we treat MCL injuries, most of us don't operate on them, and it's probably the extra-articular milieu of a blood clot healing response. So we're trying to create that situation intra-articularly in the knee. So the Bear implant's designed to restore the native ACL. Martha Murray developed this decellularized type 3 bovine collagen implant. When filled with blood, holds this clot directly against the femoral wall, allowing replacing new cells attaching the ACL native into the wall, and documented in animal studies that you all know about as early as 8 weeks. So, it's ACL restoration rather than transplant. It's innovative, and it's something we'd like to share our experience with you tonight. So we talk about preserving natural anatomy. That's obvious. The natural ligament has blood vessels and nerves, which we believe are proprioceptive and restorable by the repair techniques. If we all know that there are revisions in reconstructed knees, there are ACL injuries in contralateral knees, but in the cases of revisions, it's more like a primary because our holes are smaller. We haven't violated any other parts of the knee, used cadavers, or taken any graft source, so that potentially makes it easier. Now, one interesting topic that we talk about is the potential to decrease the prevalence of osteoarthritis. Now, that's borne out early in the animal studies, and some of the clinical studies, as we've talked about with some of the research, is beginning to show the potential of decreased arthritis. And while we're not really allowed to talk about it, it's something that we're all keeping our eye on and very interested to hear about. So we're going to jump right into some patient selection. And if my slide allows, we'll go back to that. Yes, patient selection. So we have a case that Dr. Osbahr was kind enough to bring in with us. We're going to talk about a skier as our first selection case, which will allow him to tell us about a 65-year-old woman with an ACL tear while skiing. Daryl, share with us a little about
No, thank you, Jonathan. So I know a lot of you out there may not have experience with Bear, and you're asking yourself, what's the first patient that I want to consider this on? So this would be a good patient, I would say, to look at and see how Bear could be a great option for them. So in this 65-year-old female who presented to my office, it was one of the first patients really I had indicated for Bear. Really, you can see here based on the MRI, had a proximal type avulsion injury. Some could look at this MRI and say, is it a partial tear, a complete tear? So certainly I felt that this was a good candidate. Dr. Meininger, what do you think when you look at the MRI?
I'm impressed. This looks great. For a healthy 65-year-old knee, I want to scrutinize the cartilage, et cetera. But in my screening for Bear eligibility, I want to assess that tibial stump and the retained ACL tissue. This looks beautiful. I'd categorize it as a Sherman type 2 perhaps, or proximal tear like you say. And I would definitely broach the subject of Bear restoration with this patient.
And so let's go to the next slide here for a second. And what I want to show you is the pictures when you get in there. So I'm viewing in that left-hand picture from the lateral portal. And so you can almost see the ACL and almost looks like it's intact. And I think for years, this has been what a lot of us had run into surgery. You see this great quality ligament. And then when you look around the corner in the second picture, you can see that it's actually not attached. There's some synovial tissue in the back that's kind of bridging, but the main ligament is actually off. And a lot of times in the joint environment, this ligament will get eaten up over time if you don't go ahead and take advantage of a time that you can go ahead and repair it. And so you can see in the two right-hand pictures, moving forward with the repair type procedure as I put my sutures in. So, Dr. Glashow, what would be your thoughts when you see this at the time of surgery?
I think this is a great example, and thanks for sharing it with us. And I would call this kind of that substance without integrity. You see it, it's on the wall, but it's really not doing anything. And clinically, they're really unstable. And while this is not the only case you can do a bear on, it's certainly a nice one to start with. You have a big, robust stump. It looks like healthy tissue being able to hold suture. And as Alex and you both said, I think it's a great case to do, and I'm really glad that I would have repaired this before bear. I just feel all the more confident that I can now repair it utilizing the bear. Alex, you want to jump in here?
Yeah, I would echo the same, that this ACL stump looks excellent and not obscured with soft tissue. I think it would be a relatively straightforward case to get sutures and perform the bear. So everything portended from our MRI predictions looks to be real life in vivo too.
Yeah, so then taking you to the post-op, obviously with all of our patients, sometimes you run into situations that are unforeseen. And so I was very happy my patient went back to a ski resort. Fortunately, at 3 months, they weren't skiing, but you can see here an MRI was obtained after she had a fall kind of on ice. And so at the time, she was seen at Vail, and they got an MRI. And it was interesting, you had a high volume musculoskeletal facility with MSK radiologists. And at 3 months, I certainly was a little scared when I heard, because for us at 3 months is probably not a long enough time to really get the adequate results that you really want to see. But here we can see great quality results with healing at the footprint of the ACL when we evaluate that femoral footprint. So you can see in the left-hand two pictures, we're seeing two slices, sagittal slices that kind of show kind of integration to the footprint. And in the two axial ones, which are above each other on the right-hand side of the slide, we can see healing at the footprint where the bone tunnel was located. So obviously was very thrilled. And in fact, the comment from the musculoskeletal radiologist in Vail was that it was healed, and it was a bear technique that was healed. So was very obviously thrilled and relieved to hear that.
At 3 months, that's great. That's
Yeah, it's a great example. So I think one point is we don't routinely do MRIs at 3 months because we know that the MRI quality lacks behind the tissue quality, and you can often get scared getting these. I think patients often say, hey, when do you get an MRI? What do you look at? I think before 6 months, it's really challenging. I think in the study groups, the 6-month MRIs started to look good, but it's very fortuitous to get this MRI. And thanks for sharing it with us, because it's encouraging and gives us confidence, I think, all to go forward.
Well, early in my experience with Bear, it was reinforcing to me to know that I was making a positive impact. So, as I mentioned, this is a great case for people to start off with to build confidence, just in terms of how they want to utilize Bear in their practice. But for me, it was one of those encouraging ones that let me know I was on the right track and really providing a great option for my patients.
Yeah, and talking about first cases and best cases, we're going to shift over to stump quality. Obviously, the stump quality of the tibial stump is something we all look at, and while we look to try to be able to predict that with an MRI scan preoperatively, it's not a sure thing. We often get asked by patients, hey, I want to come to you, I want you to do that Bear, but here's my MRI, can you do it? And while we'd like to believe that the MRI was the tell-all, end-all for that, it obviously isn't. But there are some things that we can glean from the MRI that can help us sort of predict with some certainty or more than just random what it looks like. So I believe our next slide is a patient of Dr. Meininger's, and I'd like him to take us through this and what he's doing with those fancy red marks on there and why they make us more at ease.
Well, clinical studies with the Bear implant suggested an adequate tibial stump of ACL tissue was required about 40% or more. So I like to use that number, and in my discussion with the patients, we can use digital measuring on screen with the MRI. And on the left here, you see sagittal image from a 21-year-old ski instructor who tore his ACL while skiing. The MRI shows a complete tear, what I'd categorize as probably a Sherman type 1 or 2, very proximal in origin. When I place the ruler or begin to denote the ligament stump, it measures up to 27 millimeters, so I'd say there's at least 60% there, and that kind of helps facilitate my discussion with the patient. I tore my ACL, what are my options, or how do I know I'm a candidate for Bear? And I can pull up this MRI, use the ruler to draw, and say, I think by these pictures you look like you're definitely a candidate, and we should put this in our conversation.
So this is your case. So can we show the, you get in there, and that was the MRI we just showed is the actual in vivo appearance here. And take us through what you're thinking when you get in there. You had that MRI, now you're looking inside and you see kind of this situation here.
Can definitely be more intimidating. The MRI, as we know, is not 100% perfect, so the real life situation becomes surprising in some instances. And as soon as we got the scope in this knee, you can see the frayed, delaminated ACL tissue. The important thing, I think, is just to take your time and use patience and work with the graft, dissecting it through arthroscopic techniques, much like you would with open, to identify your landmarks, et cetera, because what on the right looks like an intimidating, blown-out ACL that may not be a candidate for repair begins to bundle nicely as soon as you start to place sutures and you get adequate tissue and you get good control. So I just like to suggest that from that MRI picture to these images, they both suggest that this patient's a candidate for the bear, and we were successful here.
Right. So before we move on to show the next case, Daryl, you come to this and you see this in there, and you don't want it to be your first case, but as we've come to learn, you've done 40 or 50 or more than these, and I think all of us here have. Maybe seeing this first off would be a little scary, but tell us how you look at this now compared to the way you would have looked at it if it were your first or second case. What changes you've made and how you would approach it, please.
Yes, so honestly, I would still be scared. I'm scared all the time, right? And I'm scared of even of reconstructions, right? It's obviously a very humbling scenario when you operate on high-level athletes and you take care of people with these type of injuries. And so, that's where really it starts with me, is a lot of the conversations come down to when you're choosing your patients, really a conversation with the patient about what's the right option. I think our patients should be in the driver's seat more often about knowing the risks and benefits. And so, the beauty of ACL repair with the Bair technique and restoration of the ACL is that you can do a great procedure and do it with less risks. And so I think for a significant number of patients, that's a huge advantage. Now, for me, when I get in there on a case like this, I'm initially saying I'm not going to do this. Right? This is probably one I'm not going to do the Bair technique with. Certainly, as I've gone on with time, I kind of have my own threshold, and then I also have the Bair threshold, and I talk to patients about that. I have some patients that really want to go down that road of, hey, they're a believer, they loved what they've heard, and certainly think that they're a great candidate for it. And there's other patients that really, hey, I want to be the perfect candidate, and I really don't want to push the limits, and I use that information to guide me with each one of my patients about what the right option is. But certainly here, this shouldn't be a case somebody takes on as one of their first cases to build confidence off of. But certainly I think that most people find with time that they can build confidence off cases like this and great stories, because we've had those great stories already.
Yeah, I know. I think you brought up several good points, and I like the idea that patients should drive part of this equation, because like you said, certain patients who are willing to go out on a limb, they really want the Bair. Obviously, we all have discussions with our patients when we go in for a Bair. If it isn't possible to do the Bair, what's the backup? Do you want an autograft? Do you want an allograft? What's graft source? So that's all discussed beforehand, and for every case, no matter how good the MRI looks. But you see a case like this, and one thing is, it doesn't hurt to attempt to suture it. Oftentimes I'll get in a case like this, and like Alex said, it looks like a mess, but you start playing with it a little bit, you start creating some bundles together, a couple of joint sutures, and we can talk about technique a little later. All of a sudden it looks really good. Worst case scenario, you get in there, you put a few sutures in, you tug on it, it's no good, then cut it out and redo it. So sometimes I've learned by trying, it works out, other times it doesn't, but you haven't lost anything but a few minutes, and I don't really think it adds morbidity to wait a few minutes. I think this is an interesting case because we have some follow-up later in this discussion, but as an example of a blowout, and one thought I'd bring up, when I see these athletes that have these high energy injuries, I often expect to see this kind of blowout. Now, this is very unscientific. On the low twisting injuries, I see more of the proximal avulsions. I don't know if it's a pattern or I'm just trying to make myself believe that, but it's just a tidbit that goes into my decision making. When I see a low energy twisting trauma, we see more of those proximal avulsions. Those high energy injuries, we see more of this blowout. I don't know if you guys see the same or.
I would agree, actually. I thought it was altitude related with where Dr. Meininger is in Colorado, but I think especially the skiing type mechanism. Right. We call it a lot of females from Florida and they're in their 40s go skiing.
Sounds like something else.
Yeah, and so for me, a lot of those patients will have a low energy fall and will have an ACL tear that's more proximal in origin. So I agree with you. I think it's like why we see tibial spine fractures sometimes. I think in certain populations, and I've even seen them in adults. I think there is an energy mechanism that results in some of the patterning we see.
Yeah, interesting. So let's go to a different case just to shed some light on a different structure. I believe, Dr. Meininger, this is your case, arthroscopic view. Can you take us through this? Roughly how old is the patient? You know, is it acute, subacute, time frame, and what you decided to do here?
Sure. Another ski injury. This one, however, didn't get to our attention until about a month had passed. A little more subacute, if you will, than the acute instance just discussed. But you can see the difference in tear morphology, though, where the ACL is laid behind the PCL, in fact, scarred to the tibia nearly. I think some of that's an artifact of the time to presentation, but it also presents itself as a almost ideal instance where repair is maybe more technically feasible or less intimidating, and it facilitates the passage of sutures.
Good. When you see this, obviously, Daryl, this looks a bit more straightforward. How would you approach anything different, being a little more subacute than acute, and you'd be more confident? I mean, I would on this versus the first case we showed.
Yeah, I think I'm looking at this. Again, half scared, half confident with all ACLs. But the reality of it is, with this situation, I feel like you have good quality tissue there. It's just it's scarred to the wrong place because it hasn't been led to the right position. And so I know I'm going to be able to get good suture in it. The question is after you get the suture and mobilize it, are you able to get it to a good position? And to your point, Dr. Glashow, about, hey, it doesn't hurt to put suture in it and determine whether it's the right option. I mean, this is the perfect case for that because it really appears that you can have some good ligament to put back to the footprint.
Yeah, no, I agree. You know, just one technical point. You know, it's always easier for me to suture when it's attached and scarred down to the PCL. And you know, I know our time frame. I think the Bear protocol is 60 days now, max. I mean, we all may have possibly extended that timeline, but when they scar down to the PCL, in my experience, they live longer. And under tension like that, whatever suture passing device you all choose, and I'm not mentioning names, there are several self-capture suturing devices that pass that number 2 vicryl really nicely. Before detaching this stump, for example, from the PCL, suturing it directly, getting a bunch of passes in, and then taking it off the PCLs worked better for me because I never want to get those sutures really proximal because that tissue is always less robust. So I think we all agree this is a pretty good candidate for it. I think we have the good fortune, or not so good for the patient, of follow-up. And Dr. Meininger maybe can share us with this.
Well, echoing what Daryl said earlier, that you want to know and reassure yourself clinically, does the Bear implant work? And this young patient suffered symptoms of squeaking in the knee, almost sounding like a audible backyard gate that you could hear as she ranged the knee. So suspicion was for retained suture, and we performed arthroscopy at the 12-week mark, so 3 months after the index Bear implant restoration. We went back in. I was delighted to see that this healing tissue had grown in. There was a robust ACL in place of what had previously been scarred, and I think at the 12-week time frame, this was remarkable and helped me to build confidence that the implant was successfully doing what we hope it's doing.
Daryl, what are you going to say?
Yeah, so I think this is a great example of the sutures loosen up, and when we get stability about the knee and we are able to examine people, and they have good stability even with these techniques, it's not just the sutures holding the tension. I mean, this is actually graft tissue holding the tension. And you know, whether this is an ACL restoration with Bear or you're doing a reconstruction, I think we'd all be happy to see tissue like this flowing. The reality is sometimes you get reconstruction tissue and it doesn't always look great on MRI or even second look if you go on somebody who's gotten stiff or a situation like that. So this tissue looks great. It's going in the right direction. And very thankful that we're able to sometimes have pictures like this to again reinforce what we're feeling as we're taking care of patients.
I think it also demonstrates that those sutures, and we'll go over more in the technique, but act like a splint, if you will. They help support the sponge, the implant, and as it's hydrating, growing, as we're getting tissue regeneration, those sutures are going to become obsolete, become strained, stretched, or even self-rupture. They're designed to. So having to go back for a suture foreign body removal, less than ideal, but the patient still was successfully restored and ACL healed.
I think several good points. I mean, we often use, I think a lot of us, these stabilizing sutures within the knee joint or other joints to support a healing graft or native ligament. And so you showed us that video in the green room. It was super impressive to hear that squeak. And frankly, I haven't seen it exactly like that, but I've seen these internal sutures get in the way. I think it reinforces the fact that you really don't over-capture the knee, over-tighten the knee by putting this in, because we see at 3 months, it's really loose. In my experience, I've gone back in two, not for re-tears, but for some stiffness early on before we modified the protocol. And at 3 months, like you're showing us, these sutures are loose. If they're not super loose and they're not in the way, I leave them kind of as a backup. But if they're loose or we think they're causing this squeaky stuff, I absolutely would take them out. But it's reassuring and comforting to know that they do loosen up and allow the tissue to heal. So I would agree with all that. Yeah. Cool. So I think next is we're going to talk about the Baer technique, how it's listed by Baer, and the specifics, then kind of the things that we've learned over time and how we modify, and share with you guys at home what we think is maybe a little bit of a updated situation. So the Baer surgical technique, it's nothing that esoteric. It's a mini arthrotomy and a couple of drill holes, one in the lateral femoral condyle, obviously, at the near or anterior of some would say to the native attachment site, and the other for the internal brace into the tibial stump. You do have to make an arthrotomy or enough room to get the Baer implant in. I think it's about 25 by 44 millimeters, and then when hydrated, you can vary that size considerably. We'll talk about some of the specifics, but Alex, why don't you talk to us a little bit about how you started with this technique, this mini arthrotomy, some of the tricks that you like. We shared some of that before earlier in the green room, and maybe what you're doing differently now and what you've learned from your dozens of cases that you've done.
Yeah, I've taken a relatively standard approach following the technique as described by Martha Murray. The pearls I think they're most useful are introducing the graft, because the graft will respond differently to the hydration. So whole blood just drawn from phlebotomy from anesthesia is used on the back table to hydrate or moisten the graft. And just under thumb pressure and a couple moments, you'll find that it begins to soften to the texture of maybe moist grapes or whatnot. But the caution is not to overhydrate or cause the graft to crumble in your hands or lose its firm grasp on the sutures. And then introducing it successfully or atraumatically, like you say, just requires a small arthrotomy in the front of the knee. And I think sometimes range of motion may help that too, where if you introduce the graft with the knee in slight extension, 20 or 30 degrees, you can relax that capsule retinaculum, get it into the capsule, then flex to 90 degrees, and with thumb pressure, apply the implant directly into the intercondylar notch, opposed to the femoral stump.
Daryl, share with us your tricks and tips, please.
No, this is always one of the best parts for me, is sharing some of this information for you guys, because I always learn some new techniques. For me, what I think helped me a lot was I had 10 to 15 years of ACL repair experience, and I know several of us did. So if anybody's thinking about starting with this and you haven't really done ACL repairs, it's important to make sure you set yourself up for some success. And the reason is that there's some of these little intricacies, like getting familiar with the graft and how to hydrate it, as you talked about. Typically, I guess I have big fingers. I use my pinky in the portal, and then I go with my second finger. And if I know I can get my second finger in, then I know the hydrated graft can fit in well, and I don't put excess tension on it. For me, I also use a stabilization suture. So for me, the Ethibond sutures are my cinch sutures to bring in the graft. I use an extra stabilization suture to be able to help with stability, and then my ACL repair sutures. I also, instead of passing the button through the bone on the femoral side, I pass the sutures that are through the button down and the ACL repair sutures up. So that way you avoid having to worry about that button getting caught in the bone, especially because I'm always trying to make a small hole in the femoral side, trying to keep my footprint in the bone as small as possible, which I think is an advantage of the technique. And so those are a couple things that I do a little bit different, but the reality is you can keep these incisions fairly small. You can also modify the procedure a little bit to what you're comfortable with, especially in the beginning.
All good points. I think you were talking earlier, you were saying that your drill size is about a 2.4, if you don't have to pass the button, a 2.4 millimeter drill. But And to your credit, you have 3 sets of sutures now. You have the sutures in the graft, you have the stabilizing suture, which is extra, and you have the ethibond that Martha Murray describes going through the Bayer implant. And a lot of what we do is suture management from shoulders and knees. So one of the things I do is make an accessory anterior medial portal just to park sutures elsewhere so I don't get too confused. I'm not as smart as you, so I have to have them separated. The graft takes a little experience in my experience has been some of them hydrate quickly and some of them are not so quick. But you always want to, I feel, you should always err on the side of it being a little stiffer. It always gets softer, it never gets any stiffer. So, I call it the al dente move because we have a lot of Italian restaurants in New York. So I get it kind of firm, especially on the back end, and I try to use one of my fingers and get it in. And you can make the skin, because a lot of people want those smaller skin incisions. I think and that'll stretch, but the arthrotomy site has to be adequate, because if you don't have an adequate arthrotomy site, in my experience, you shave off some of the implant as it goes in, and that could lead to other issues that we can talk about later. So I think it's important to have enough arthrotomy opening to get the graft in, and then you can close it through that small skin incision. We were talking earlier, I use the suture passer that I pass the ligament sutures in, and I use that to close the arthrotomy so you don't have to extend the skin incision. But I think it's important to get confidence that the stump comes back to the wall. And one other thing I do is I'll pass the graft sutures separately, and while I'm in the arthroscopic portion of the procedure, I'll demonstrate to myself that I can pull those arthroscopic sutures and it comes up to the wall. If it's not coming up to the wall, maybe antralize the femoral drill point so you're closer there. And in that way, you also don't violate potentially some of the fibers of the native ligament or there. So there's some of these little tricks I think people should hear, because I think it'll make you feel better. If you can see the ligament going up to the wall, you'd be more confident, and it takes some of the tension off if you come up a little bit anteriorly. How about on the tibial side? What are your thoughts to that? Do you go right through the stump with your internal brace, internal suture, or what do you think?
Yeah, my tibial tunnel I drill with a point-to-point guide that's ring-based, and so the ring allows you to compress the tissue, keeping the tibial stump free of iatrogenic injury. So through your standard pretibial incision, you can drill up a 2.4 millimeter pin. If you're compressing the ACL tissue with the graft, then it penetrates relatively easily under tension. I found that if it's not compressed, it may get wound up, or you can cause injury to the tibial fibers, and I think it's helpful to stabilize it.
One point we didn't talk about is, unlike traditionally, we all want to look at, what we did. So I've always been frustrated that when you put the graft in, you tighten the sutures down, and you can talk about the order. I like to, tie the internal stabilizing sutures first, and the very last thing, tie the graft sutures. And then, of course, I want to go look at it, but you can't flex the knee. And I don't know if everybody's picking up, I'm sure whoever's doing this is going to learn that, but you can't bend the knee once you get this all set up. So that's why I pull the sutures up beforehand to give myself that confidence. But you can certainly do a Lockman, and I do a robust test, as I'm sure you guys do before leaving. What about notchplasty? What do you guys think about? Do you do a notchplasty? Do you do any sort of venting holes, or what's your thoughts on that, Daryl? What do you think?
Yes, per the protocol, a notchplasty is needed, but I do enough of a notchplasty just to create bleeding in the knee to help augment healing potential there. Because really, again, the difference here is trying to restore the native ACL and trying to bring in clot formation and trying to hydrate that area with bleeding potential and cells to help augment healing and scar tissue formation. So for me, the important part about this is getting out the synovial fluid, as you described before at the beginning, as well as enhancing clot formation to be able to achieve those goals. For me, on the tibial side, one thing you had talked about, I agree, putting tension on that area will help you pass it and be atraumatic to the native ACL with the stump that you do have. So I think that's essential to what I do as well.
Yeah. One other minor technical point is, we talked about this before, is that when you have that lateral button on the femur, we're tying the ACL sutures directly to this button. So in order to be sure that that button is against the lateral cortex, Daryl, you brought up a good point. What you do, and I'm learning from you, you look directly with the scope, put the scope in the lateral incision, and you can actually see it. Now, I'm not that good, so I take a single C-arm image, and I want to make sure that button's affixed against the wall. But if it's up and then it wanders down, your stump's going to be loose. So I think those little minor things that I think sort of learning points have really helped me, and it's really translated into really tight knees. I mean, I'm kind of impressed with what I'm seeing.
No, I think two things that you pointed out, that femoral small incision line, I think is very important. I don't make it big, it's less than a centimeter, but I make it big enough to be able to fit the scope down and make sure that I do not lock my suture as I'm tying it down on the femur when I'm doing my repair. And so I'm able to follow the scope in and look in the direction of it and see the button directly on bone. So I haven't needed to use X-ray for any ACLs in doing that, and haven't had any evidence of any of them getting caught in the tunnel, which sometimes we can see because it slides in. And so I think for me that's number one, but also the tensioning of the sutures. The vicryl suture you can lock a little bit more than some other sutures, so you just need to be thoughtful of really pushing it down to bone and tensioning it. And then having a backup if you did lock it, just making sure you have a backup. But this is why it's important if you haven't done ACL repairs before, just to potentially practice this and do it and get comfortable with it to make sure you put yourself in the best position, because there's those little idiosyncrasies.
You know, I spent 1 minute talking about additional procedures. I mean, do you guys, for instance, do a lateral LET type procedure with this? Have you ever done it with an MCL? And if so, how do you order those procedures? How do you get away with this and the additional? I'm happy to give you my thoughts, but I'd like to put you on the spot first.
Yeah, absolutely. I'm not an LET person, in all honesty. I think people that have chronic ACL deficiency and develop some more rotational laxity with a high-grade pivot shift, or your true hyperextenders, and I think are the candidates in my book for it. But I am not a person that looks to do the LAT on too many people. I think there's a lot of controversy about it, but I don't technically look to add it. I have no fear of doing a repair with any other concomitant procedures like meniscus repair or other multi-ligamentous knee injuries, and I have done this at the same time as doing those procedures with a lot of great success. And interestingly, in those patients that you do have a multi-ligamentous knee procedure and you do this in the intra-articular environment, you're creating less scar tissue in the intra-articular environment and potentially less chance for stiffness, which is obviously much more common in a multi-lig population.
Yeah.
I think it's all about pre-op planning, and I've had posterolateral corners and MCL graft reconstructions, but recognizing that in my ACL graft patients, you might implant the entire graft, delay tibial fixation, pursue your concomitant procedures. You just have to think ahead that the bear, you might do your tibial prep, your femoral prep, place sutures, then perform your extra-articular reconstructions before you introduce the implant, because once it's introduced, the range of motion is locked in extension for the. So it's just important considerations relative to the bear if you're going to have to do anything else. But I don't think those are contraindications to bear either.
I think you made the point, and I think it's very important that you can do these additional procedures, but planning ahead and making sure the last thing you do is tie those, or implant the bear and then tie those sutures. Otherwise, you can still do MCLs. And actually, my threshold for doing an MCL is lower with the bear because I want to be sure that I have a stable knee. And if it's like on the fence, I'll put a supporting suture on the outside to protect the MCL, just because I don't want excessive stress to the bear. And you can do them, and it doesn't interfere as long as, like you said, Dr. Meininger, you plan ahead, and the last thing you do is put the bear in and keep it locked in full extension. Any other tricks or tips you want to go over? What device do you like, or you just use standard suture passer when you're grabbing the
Yeah, taken from the shoulder environment, but a single-stage suture passer, multitude of manufacturers, et cetera, they all work pretty well. Smaller inclined needles, I think, work better, where in the shoulder you're used to a number 2 cord suture. In the knee with a number 2 vicryl, it's a little more vulnerable, so some of the lower profile knee-oriented instruments may work better and less traumatic or less likely to rupture the suture.
So standard equipment they use in other cases.
Yeah, I'm the same. I use a standard suture passer, self-capturing, to be able to go through it. I'm just very cognizant, especially with good quality tissue, of trying to get suture through both bundles to be able to make sure I tension them. And sometimes it's very discreet. You can see both bundles, and sometimes you can't. But in those cases, I want to make sure I do capture both.
What I think is exciting, too, is that when you place your sutures, you can put it under traction. Use your grasper and draw that ligament stump into the notch. You can lay it against the wall, but it just helps to reassure, prove to yourself that I've got good tissue quality, good suture bite, and I can handle it well, that it's going to oppose in the reduction I give. So.
Right. You were saying you get 4 or 5 passes at a lot of these
Try
stumps.
to do an arthroscopic Krakow, usually 5 passes from right to left, and with a little patience and healthy suture management and an assistant, it usually becomes pretty fluid. So.
Agreed. Well, I want to save some time to talk about the physical therapy and the post-op regimen, because obviously it's a little different than what a standard reconstruction is. So if it lets me advance, we want to talk a little bit about the different parameters of physical therapy, the obvious issues of crutches, braces, when to start PT, how long to to do physical therapy and obviously the return to sport protocol, which in a lot of ways shares with typical reconstruction. So, Alex, you want to start us off on what you do? It sounds like you're pretty regimented with Martha Murray's description of post-operative care, but tell us what that is, please.
I do. I follow the manufacturer's guidelines and the original rehab protocol, or the adapted rehab, I should say, from last year's changes. But I think the important part about the Bayer protocol and the Bayer recovery is you have this conversation early. You're talking about the recovery, you're talking about imposing restrictions before you even get in the operating room. I think it's helpful that these patients understand that restoration is more delicate. It's not a graft that's screwed in place. We're wanting tissue to heal itself and to bridge. And if they are bought into the suggestion of Bayer and they understand there's limitations and they know now why, their range of motion may be gradual or they're on crutches in this instance compared to what might be possible with an ACL graft. So what that means is that the patients have restricted range of motion. I use the hinged brace with 40 or 45 degrees allowed for the first 2 weeks, and it increases to 90 degrees at the 4-week mark. And by 6 weeks, they're done with the brace, which is relatively routine for my other ACL patients. And regardless of concomitant procedures, the Bayer implant is partial weight bearing or touchdown weight bearing for those 4 weeks, and then between weeks 4 and 6, they work to weight bear as tolerated, and hopefully walking without assistance at the weeks 6 and 7.
So first 2 weeks, 0 to 45, then up to 90 by week 4, partial weight bearing, 4 to 6 weeks. After 6 weeks, no brace.
Right.
Daryl, what about you?
So for me, it's very similar protocol. The only exception to me would be meniscus pathology. If I have a very unstable meniscus tear, including something that's one of those small oblique tears in the back of a posterior lateral knee or a radial tear, then those are the times that I will protect their weight bearing more. But otherwise, very similar to the guidelines. What I would like to point out is it's been interesting, as we mentioned before, and Jonathan, you've had an extensive history with ACL repair even beyond this. My technique in the past used to be, oh, this is like a knee scope, right? And you're trying to move people quickly. And I think I've learned a lot through my Bayer experience about, should we be moving these people quickly? You know, we don't want to pull the scab off, and we want to enhance scar tissue formation. And although our patients will do really well if we move them quickly, no matter what we do. Same thing in a shoulder with the rotator cuff. If you just move them and just get the motion, you might do great from a motion, but you might not heal the cuff. And it's the same thing here. For us, I think we need to be conservative in the beginning to enhance healing, to hopefully get the benefit later on that when we have a good ACL repair site and restoration site. And so that's where I think I've learned a lot through this process in the last several years of my experience, and really make me have perspective on that.
Yeah, I think you both bring up some really valuable points, and from a practical standpoint, I think it's challenging for some of the patients. The preoperative counseling, I think, is huge. So I had 2 patients who knew each other side by side. One had the Bayer, these are 40, 50-year-old women, and one had an allograft. And 2 weeks out, the allograft comes in, and she's got 90 of motion, no crutches, run around, and the Bayer patient is like, whoa, what's all this about? And having pre-warned them that, hey, the race isn't over at the first turn. The clubhouse turn, let's see who's ahead. And at 3 months, the Bayer patient actually was ahead of the allograft and was stronger. We talked about a little bit later on. So I think the 2 important issues, or a few important issues, are the range of motion. In my world, if I'm super confident about the suture grip early on, I'll move them a little faster. I think it's key to get to 90 degrees by 4 weeks. I had a couple issues on my rescopes that I went in for where a scar tissue, and I just couldn't get flexion. Extension's fine. It's sort of paradoxical to what we're used to. And so I think part of that is protecting them too long, and when I didn't make maybe a big enough arthrotomy early on, and some of the implant got displaced off and got caught up in the suprapatellar patch, so I went back in those couple of relooks and found this huge amount of scarring. I haven't had that happen in a year and a half or so. My oldest one is over 2 years now. And I think that if you get them to 90, it's at 4 weeks, you've still waited long enough, but you haven't jeopardized that lost motion. I'm not so worried about weight bearing. I don't know. It just intuitively, if it wasn't a meniscus tear, I think I allowed them weight bear a little earlier. It gives them more normal feel. And if you get them weight bearing in a pool early on, I think it's another way to do partial weight bearing and restore the foot kinematics and that sort of thing. Take a moment to talk about a little bracing. You said brace 6 weeks. You put these guys in functional braces when they go on the mountain in Colorado, or what do you think about bracing? Different than a reconstruction? Same? How do you look at that?
Good question. The original protocols called for the functional brace after week 6 and through week 12. So like you've been doing this about 20 months, 22 months, and those early patients were strict by the book per the protocol. So functional braces were fitted around the 3-month mark, and as they were already in their possession, I've advocated that those patients that might be apprehensive or need that psychological reassurance, I think skiing or non-contact sports with the brace on is encouraged once they're released at that 8 or 9 month mark.
So have you had a re-tear that you could attribute to a failure of therapy, or have you changed therapy based on re-tear? Have you had any re-tears, and if so, have you changed your protocol based upon that for those reasons, or share with us, please, your insights?
Yeah, of course there's failures, and I've had a Bayer implant be revised to a graft. I don't think it was due to the therapy per se. I think it was either bad luck or repeat trauma. Adolescent age patient got caught up roughhousing, or the knee buckled and was tripped, attempting to rehabilitate it, but proved to be unstable and was stabilized with a reconstructive graft. But
Yeah, a self-serving question, because I had one, and it's like a 15, 16-year-old gal, a soccer player. I just didn't think she was really diligent with her therapy. She was on TikTok most of the time during her therapy sessions, probably didn't do it. Strength wasn't there. Mom wanted her to go back to play soccer, a couple months in. But, I've had that same scenario on the reconstruction. So like you, I revised it to a telegraphed and did fine. But I think the point I'm trying to make is that you really got to choose your patients wisely. And we showed a 65-year-old or whatever patient, maybe they're better to start with because they're more compliant. This 15, 16-year-old adolescents, maybe to Daryl's point, maybe, if they're not going to do the therapy, if they violate that early protected range of motion, maybe that's where some of the failures are. Not sure, but it's a thought of mine. That was my single experience of a re-tear. What about you, Daryl?
Yeah, I think failure is an interesting word, right? I think a lot of us feel like failure is often when anybody gets re-injured, but the thing that keeps coming to my head all the time is I've had re-tears and failures in all patients, right, of every type of surgery you can have. And so fortunately, so far, I haven't had a re-tear. I've re-scoped one person, which really wasn't stiff, but felt stiff, probably just some anterior adhesions that were bothering the patient, but that's the only kind of re-look that I've had. But I've had a lot of success with it. But I think overall for me, I think ACLs re-tear. The younger age population, the more younger people you take care of, the more likely you're going to have re-tears. The more you're doing it in young female soccer players, the more likely you're going to have re-tears. But what it rings to me is that, ideally less chance for arthritis, which in the animal studies it shows. I think less chance for stiffness. And when you do get a feeling that they're going slow, it's not the same stiffness as an ACL reconstruction gets. And I've never had a situation where I've had an ACL repair with the restoration technique where I felt like, oh my God, I wish I had done a reconstruction. My thought in my head has been, thank God I did a repair with Bayer, because I think they would have gotten stiffer, or they would have had a slower course with the reconstruction, because the impact a reconstruction can have on the knee as opposed to this procedure.
I was going to say the inverse is probably true. There's several reconstructions you probably wished you did the Bayer on, because they're less invasive.
Yes,
less hardware.
As long as they're compliant in the first 4 weeks.
Right. So we have a couple of videos. I think Dr. Meininger can take us through these, but I want to save some time for questions. We have limited time and appreciate everybody's patience. So I think we have a couple of Dr. Meininger's patients, one gal in particular. Can you take us through this, Alex?
This is an exciting case, one of those you're proud to broadcast, but 17-year-old high school basketball player. These videos are taken at 7 months post-op, and they help me to answer that question again. Does the Bayer implant work? And I think that being less invasive, inducing less muscle atrophy, may facilitate a quicker recovery, and getting an athlete back to sport, as shown here, playing basketball, I think is amazing. So this is at 7 months. She's already outpacing her father here. So this is after Bayer with no brace. So
I think you have some data to show us. So I'm just going to move us along a little bit. And one point we talked about being a less invasive procedure, not stealing part of the extensor mechanism. And I think about healing of a ligament rather than a graft is different. And so what are you showing us here in these numbers? They look very complicated.
These are some of our return to sport tests that are done for our 8 and 9 month return to sport exams. So we want to do isokinetic knee flexion, knee extension, strength tests, compare symmetry right to left or surgical to non-surgical. What I found exciting in this patient, the same basketball player we just showed, is that her hamstring strength on the Bayer side was 105% of what she had on the opposite side. So I think it just demonstrates that by retaining muscle mass, not violating normal tissues, that strength can return or even become greater than what they had before. And that strength, proprioception, neuromuscular response, I think is how she's going to be successful in the long term, I hope.
And this is 8 months, just to remind
Yeah,
us all.
at 8 months.
Yeah, nice. Daryl, do you want to add to this, please?
Yeah, physical therapy is so important, and I think a lot of times in an orthopedic surgery world, all we do is focus on the procedure. But the best procedure with poor therapy will end up in a poor result. And sometimes if you have really good therapists around you, you get really lucky. And so I think for me, I'm thankful to have a lot of great therapists around me for any of those that are watching. And the reality of it is that going through this process of preventing re-tears is a multidisciplinary result where we have to affect the psychology of the athlete, we have to affect how they return to play and return to the same level of performance. We talk about that a lot. Just because they pass the numbers doesn't mean they still, when they go out in an unpredictable situation, that they're really ready to incur that stress or be able to put the endurance of their body through it. Do they fatigue, for example? So I think for us, these are the building blocks of what we really need to do to make sure that our patients are getting back well. Otherwise, we're going to continue to have re-tears of every type of ACL procedure we do.
Yeah, I think, again, several good points. I mean, so maybe not a failure of biology, but a failure of fitness. If the muscle strength, proprioception, everything else isn't there, they're going to re-tear. And I'd say, like you, to the patients that, you tore your native ligament. There's nothing that we can do that you can't re-tear. And the best predictor of longevity and best predictor of lack of re-tear is fitness once the biology is healed. And by the way, I think the biology heals more quickly. I mean, just simply speaking, putting a ligament back together to the wall rather than a graft implant, you would think it healed quicker, but you really need to rely on your therapist and the patient to have strength, conditioning, proprioception, all the things we talk about in return to sport. I mean, the average NBA player is about 12 months, 13 months, and it's that amount of time it takes in the ideal situation to restore fitness, strength, conditioning, and then a gradual return to the particular sport they're in. So the failures may not necessarily be the biologic failures, but they may in fact be the rehabilitation failures. And I agree with you. I'm very thankful for the therapists in my world who make me look better than I am, and grateful for them. I know we're out of time, so I just want to talk a little bit, look back at our past patients. I've been doing this since October 21. I think you guys are similar, and we've had a number of patients that stick in our mind. And I mean, I can share my first case was a young adolescent who was playing football, whose dad was in the medical profession and was set to do an invasive open procedure at another hospital. And so I discussed with the dad this what I thought was minimally invasive technique, and he reluctantly went for it. And I was saying earlier, I still get love notes from the mom showing me his football pictures, and he's grown probably 6 inches and 50 pounds. So I was sold. And in comparing that to what he would have went through with a tendon transfer type procedure at a children's hospital, I think it's impressive and grateful for. I think we have a slide of Dr. Meininger. So this is the familiar case, and can you share with us what we're looking at here? And I think we have a follow-up MRI. Then we'll get to Daryl and have his thoughts.
No, this is that exciting case of the exploded mid-substance ACL tear that we reviewed previously. So the pre-op MRIs are shown on the left, intraoperative photos here again, and this was the case that I was somewhat tenuous about until we could get good suture control. Had him back in the office last month for a 10-month post-op MRI, and these are the results of a graft that had healed. In the T1 sagittal, you can see there's heterogeneous tissue within the intercondylar notch, and on the coronal views, it's adherent to the lateral femoral condyle. So this MRI was very positive, and I was excited to see how we can get this result from where we started.
No, I think it's great. It's great to have the follow-up MRI. Just before we go to the question bank, Daryl, you had an interesting, what are your most memorable initial or early cases that you can tell us about?
Well, number one, putting my foot in my mouth for saying that I don't know if I would have repaired them. So number one, again, humility. So great work and great job. But for me, I think the turning point for me, especially with this technique, and it was very personal for me, was my wife tore her ACL. And she was one of those 40s female people that went skiing, and had a little bit more of a mid-substance to maybe kind of an 80-20 tear, somewhere between a 2 and a 3, and really did a lot of thinking. First, when I had to tell her she tore her ACL, when I took her off the mountain, and then second, when had to decide what we were going to do for her. And so, but this was a moment where really I thought about kind of what I thought was the best option and what I trusted, and that, you know, ACL reconstruction surgery is not a perfect option. And I think that's what we get away from a lot with a lot of our patients is the fact is the injury is destructive, the surgery can be destructive, and long-term outcomes are not just re-tear rates, they're also long-term satisfaction, less stiffness, more functional knee, return to sports and recreational sports. And so that's how I led me to the result of suggesting my wife and have an ACL restoration procedure with Bayer. And she's 18 months out, doing great, back to playing tennis, back to doing ropes courses, and at some point she'll beat me on the tennis court.
Impressive.
That's awesome.
Impressive. Well, thanks for sharing that personal note. I think we need to open it up to some of the questions. I think there's some questions that may have come in during the program. If you have questions, please enter it in the Ask the Question box at the bottom of the screen. So question one, have you anecdotally noticed a quicker, immediate post-op rehab in terms of pain and return of quad function compared to reconstructions given smaller drill holes and no graft harvest? Who wants to take this?
I'm happy to. So this is an interesting part of it. I think the quicker you move people, in general, that will build quad strength more. The less you brace people, build quad strength more. The more you weight bear, they'll get their motion and build strength more. So I think part of this is a function of the physical therapy rehab just as much as the surgery. What I would say is that when we get down to the numbers, you look at IKDCs at 6 months, patients that have had the Bayer technique versus a reconstruction, their scores are higher when it comes to these things. And we saw the numbers that Dr. Meininger showed even with his patient. So I think whether you see that at 6 weeks or 3 months, I think part of that is the rehab component. I haven't necessarily seen that quite as much, but I've seen people doing better with this procedure with less impact on them and less struggle with the therapy program initially.
I was going to reiterate that at that 2-week post-op check, they look more like a meniscectomy patient than they do an ACL reconstruction patient. They're getting some quadriceps activation early on. Their challenges getting to terminal extension are limited compared. So I would agree with this question that I do see a quicker, immediate post-op recovery in these Bayer patients compared to the graft patients.
Yeah. So I've had several patients who've had a traditional reconstruction on one side and come in for a Bayer, and that's their anecdotal experience, if you will. Maybe their memory isn't so good, but intuitively it makes sense. You're drilling 2.4 rather than 10.5 millimeter holes. You know, you're not harvesting a graft. So yes, thanks for the question. I think it is true, and I'd like to see it borne out in the literature in time. And if we all collect our data and share it, I think we'll see that. Let's go to the next question. Would you do this procedure on high-level athletes or just weekend warriors? So I've done it on D1, Division I football players and semi-pro soccer players. And I think it goes back to what Dr. Meininger says. It's about patient discussion. They're just people. And if they think you explain to them the rationale and the pluses and minuses, I think their coaches have been trained to dissuade them from doing the Bayer for some reason, but I have no hesitation. I treat them like the others. I think once this thing heals, it's as good as anything else or better. So I wouldn't have any reluctance. I think the pros are a little different because of money, but I think pros have come to me for this, but reluctant to do it because they all want to know who's the other pro you did it on. And I haven't been able to say, so I'm waiting for Daryl to do it on somebody big. And that's why I can say, I know somebody. What do you guys think?
Yeah, so for me, this has been the one area that I've been reluctant, but have done it on high-level athletes. And so I think this comes down to the conversation point with the athlete, just as you said, Dr. Glashow, is just, you know, what is their goal? Have they heard about the procedure before? What's their comfortability with it? But this is something where I go into every single patient interaction explaining all the different options they have. I even tell every patient about a COPA program, just so that they know people do cope without an ACL. So I talk about every single option with the patient and go through with them, pluses or minuses. And so every patient that walks into my office is going to hear about a repair restoration procedure with Bayer. And then I'm able to counsel them as they tell me their fears. But I do agree with you. The high-level athletes, it's for all of us that treat high-level athletes. The concern is what are the people around them saying just as much as them? Do they go back to their locker room and the athletic trainer's like, I've never heard of that, you can't do that? Is their agent saying something in a pro athlete? So you have to be very counseled to communicate, and that's what I found is communicate with everybody. on the team to know why you're making the decision and why you're talking about this and why they're a great candidate for it. And if you inform everybody, then you're more likely to get buy-in on some of those people.
I think you're absolutely right. And this scholarship freshman football player, I guess about 6'3" and 300, I had to talk with the coach and talk with parents. And once they heard it out, there was a lack of education. And then they understood it, and they understand the lack of invasiveness. And then they were interested. We did it. He's 6 months out, solid as a rock, but not playing this year. And I think as it catches on and more of us do this and take the time and explain and convey the message to the therapists and the trainers, I think it'll become a more prevalent. You want to add anything to this, Alex? I think we covered a lot.
I would echo the same, and I've seen successful results in ski instructors, ski patrollers, and a Division II college tennis player, same thing. So some reluctance, am I confident this is going to work? And I think we've shared some data that we get restored tissue, and I'd be open to discussing it with all patient types.
And here's an interesting one of that question. I asked myself, would I do that on my daughter or my son, right? And so both play sports, and I tell you, knowing what I know now, I would want to talk to them about this option, just given what we've seen. And number two, weekend warrior, I guess you can call me one, and I would want the procedure done on me. That's what my physician assistant and I talk about all the time is, what would you do at this age?
We have the same discussion. I would do it too.
Yeah.
I absolutely would. You burn no bridges,
Right.
and our results, if you come to the clinic and see, bear this out. I think we're going to go to the next question as they're pushed us. How would you counsel a patient on the long-term OA risk in the absence of long-term data? Well, I think you can tell them that most of the ACLs we do now that I'm seeing back 20 years out, so I'm old, get arthritis. And we don't know exactly why, but part of the natural history in my experience and in data experience is that, yes, you tear your ACL, you have a reconstruction, you're at a greatly increased risk to developing osteoarthritis. I don't think that's debatable. Now, we can't say and shouldn't say that there's data out there that shows in humans that we're preventing osteoarthritis. That I don't say, and I don't think any of us should. However, there seems to be some hints in the early animal studies, and maybe some hint of it in the early trials, the human trials, that suggest it. I think beyond that, I would be uncomfortable making an absolute statement. It seems like a trend, but we know what happens if you do traditional, and that's not so great. So anything that improves that, I would feel would be a benefit. What do you guys think?
Yeah, so for me, scar tissue causes arthritis. I think we used to always think of, is it the ACL, is it the partial meniscectomy that used to be performed all the time, which a lot of the long-term reconstruction data is based off of patients that, is it the ACL, is it the fact they don't have meniscus anymore, and why we're so aggressive with repairing the meniscus. But to me, scar tissue is bad in the knee. For reconstructions, I'm much quicker to scope a knee knowing that they'll be better off long-term with less scar tissue. And I think we've all seen it where you get patella baja because the patella is socked down, you get scar tissue into the gutters, and you're wearing away cartilage in those areas. And so for me, I personally believe, even though we don't have the data yet, less scar tissue leads to less long-term arthritis. And so if we have a procedure that enhances that, then we're able to prevent it. I think the animal data is encouraging, but I think we'll obviously need more long-term clinical data to really bear that out.
Well said. Alex?
Yeah, I agree. I think that we know the natural history of graft reconstructions. We've seen those arthritis patients. I suggest to the candidates that we have the potential that we can reduce arthritis. We can restore the knee. Tension, isometry are different than pulling as hard as you can on an ACL graft.
And maybe leaving some nerves and blood vessels in the native would help us. Let's go to the next question. Would you share your experience of when you had to convert from a bare to a traditional reconstruction using a graft based on intraoperative findings? I mean, I'm happy to take this because I've done it a couple of times. You know, certain patients come in and they say, you know, no matter what, if you can get sutures in, I really want you to do this. I'm sure you guys have that scenario. And so you try what looks like not an obvious bare candidate. You go in there, try to pass some sutures, and I pass a bunch of sutures, and then I tug on them. I bring them out to that lateral wall, either with a knot pusher using it at the end of the suture or some other device, and I look to see if it'll hold. And I pull pretty hard to try to mimic what I want to tie it as. And if it doesn't hold, I give up. But that process of putting those sutures in and testing it, is it 10 minutes? I think 10 minutes would be long. So it adds a little bit of time to the case, and then I'd say, you know, it's not going to work. Cut it out and go back to plan B, and we always have a plan B as we talked about earlier. So that's my experience. Alex, what would you add?
Yeah, it's similar. I think the cases where I've abandoned Bear and chosen to go with a graft in this instance would probably change course if I were to go back on that same patient today with the experience and what I know now, having done 30 plus Bears so far. I think that the tear quality, the tissue types that are left are still amenable to suturing, and I think that more and more of them are actual Bear candidates, and it's rare then that I find one where I have to abandon our approach to Bear and pursue a graft.
So there is a learning curve.
There is. It's not necessarily in the technique, it's in your appreciation for what can be done with the tissue you're given.
Yep, I completely agree with that. I think for us, if you don't feel, it's a gut feeling, I think for all of us, and there's some of these tips and that you can utilize to be able to assess how the quality of the suture is within the tissue. But at the end of the day, each surgeon has to evaluate themselves, and I'm pretty confident, as Dr. Meininger said, as people go on with time and get more and more comfortable with this, you'll probably be indicating more and more patients, and that's what I think we've shared has happened at every single one of our practices, is just getting more and more comfortable, and then getting those MRIs and getting those, whether it's a second look you need to do for another reason, and being like, wow, I like what I'm seeing.
Yeah, good. The second looks are very reassuring. Do we have time for one more, or I think that's all the time we have for this evening. When you close out the broadcast, please take a moment to complete this survey, if you would, regarding tonight's program. We want to thank everybody for taking their time tonight out of their busy schedules from home for joining us. A special thank you to our Dr. Osbahr and Dr. Meininger for joining us. I've enjoyed the interaction. I've learned a lot from you guys, so thank you, and thanks for making the trip to New York.
Absolutely.
No, thank you very much.
Thanks, everybody. Good night.
Thank you.